Yeah. We'll go on to the next questions. SCLC on cisplatin etoposide. Creatinine is increasing. What is the next management?
Discontinue cisplatin and initiate hemodialysis.
So switch to carboplatin.
Is
It
there
was
any in for dialysis given in the question?
yes, sir. What is next step?
So adequate hydration.
Adequate hydration before and after chemo is out now because already the patient has raised creatinine, right? Dose reduction of cisplatin is also not the story. It's either B or C.
It is
Six.
sir. We discontinue the cisplatin and switch to carboplatin from next cycle, sir. For present cycle, in which the patient has landed into AKI type, we should discontinue and initiate the hemodialysis type. It was there, sir, in the question.
So this was
No,
not
where
deep question.
was the question having some pointers towards need for hemodialysis? Just because creatinine is going up, we are not going to dialyze.
So no such point regarding hemodialysis.
There are no clues to say that the patient will need dialysis, then B is the right answer.
So they ask how to mitigate cisplatin toxicity. How will you mitigate?
Will you mitigate is adequate hydration before and after chemo? But
Yes,
again,
sir, it
taken
was
for
how will you
granted, they should have given proper hydration. In spite of that, it is going up. That is how we are supposed to understand. None of the cisplatins are given without hydration. No one gives, obviously. And the funda of giving cisplatin itself says there should be hydration pre-post. Let's go one by one. Dose reduction of cisplatin, is it going to help?
No, sir.
No, sir.
Yes or no?
No, sir.
So is it dose dependent toxicity? That is the question indirectly asked. Is it a dose dependent toxicity? Is nephrotoxicity a dose dependent one? Is this a dose dependent toxicity? Just because you reduce the dose, will you expect the next cycle that nephrotoxicity will not happen?
Sir.
Sorry?
So I think no.
It is
So
dose
it is all
dependent.
dependent on the hydration component and the other comorbidities which might push patient towards a nephrotoxicity. Yes?
Yes, sir.
Understand? Yeah.
Yes.
So dose reduction is out totally. If they are asking for this cycle, obviously adequate hydration before and after chemo is not the answer because already the creatinine has risen and adequate hydration as a general term is not acceptable at all. So A is also out, D is out. To choose between B and C, if they are asking only what is the further management to mitigate the problem, it is to switch to carboplatin. In terms of two things, they are not going to ask you what are you going to do in terms of medical management now. They are wanting to know whether switching to carboplatin will be a good treatment in an SCLC patient. Switching to carboplatin, is it good in cervix chemoradiation?
Inferior results, sir.
It is the inferior results, but in SCLC we can do, sir.
So where all carboplatin can be replaced in cisplatin place.
In ovary we already use
Head and neck,
carboplatin.
head and
Okay,
neck we
good.
can replace, sir.
Head and neck, can you
inferior
replace?
result.
Head and neck, can you replace?
No, sir. Inferior results.
So one is ovary. Anything else?
Esophagus.
Esophagus for what?
So we give factory carbo in a concurrent chemoradiation.
That is not a replacement for cisplatin. Okay. In bladder, yes.
Yes, sir. Gem carbo we can
Or
sometimes.
cis. Either of this is accepted in bladder. And second thing is your ovary. Same way, small cell lung cancer, even the guidelines say carbo or cis based on the eligibility for cisplatin. Okay. So to me, answer is
B. Hello.
just a minute, a small emergency. Yeah. So it is discontinue cisplatin and switch to carboplatin. Okay.
Yes, sir.
Shall we move on?
Yes.
Any further discussions needed?
So,
Sir, for cisplatin, on cisplatin, if the patient goes on like for creat 3.5 or 4, like hemodialysis, we don't do, sir. Like, how do we reduce this serum creatinine, sir?
No. Why do you want to dialyze just because a creatinine is rising?
Like thinking like patient landed in acute kidney injury.
Yeah, acute kidney injury, raising creatinine, all accepted. What are the indications for dialysis in a patient with AKI? 1, 2, 3, 4, 5. You don't dialyze every patient with rising creatinine, right? Just because the creatinine values are scary, doesn't mean you are going to dialyze. What are the indications for dialysis in any patient with AKI?
Acidosis and electrolyte imbalances.
Metabolic
Anemia.
disturbances, resistant to therapy, dyselectrolytemia resistant to therapy, volume overload resistant to therapy, uremic pericarditis or uremic encephalopathy. Anything else?
Toxins or
Sorry?
drugs. Toxins or drugs.
Toxins or drugs itself is a dialysis indication for that product, not for the AKI part.
Okay.
Okay. So, set indications are there in a patient with AKI to initiate dialysis. Not that everyone who lands up in a rising creatinine will need a dialysis. You just hydrate in this patient, and if creatinine falls down, you don't have to dialyze at all. Obviously, right?
Yes, sir.
So, doesn't mean you'll have how many dialysis units we'll have, how many creatinine rises you are going to see. That is totally unmatchable. Okay. So, if the patient is anuric also, unless until they go in for a full shutdown wherein they are not some kind of still responsive to fluids, then you will have to do a dialysis. Okay.
Yes, sir.
First step,
Administer broad spectrum antibiotics.
so indications for GCSF in a patient with febrile neutropenia. What does it do?
Increase the WBC count, sir.
That is very known fact. Does raising the WBC count with GCSF make any changes in the outcome?
No, sir. It only
Reduce the
shortens the
morbidity
duration of
score.
Days of admissions by hardly a day or two. You got it?
Yeah, it decreases the
So we don't
duration.
have a strong evidence to give. We are giving that is different. But
Yes.
by science, by research, it is not a very strong evidence to give GCSF for all patients with febrile neutropenia. Okay.
Okay, sir.
These indications are very, it's not very strong. Even indications for granulocyte in a patient with febrile neutropenia sepsis shock is also not very strong. Because we cannot prove it. That is the problem. You cannot subject a patient with febrile neutropenia to give GCSF and another patient with same story to not to give GCSF and then check who is improving. That is practically not possible, right? You can do the same in a patient who is low risk. Immunotherapy related hepatitis management, what to do? Change to another immuno, yes or no?
No, sir.
No, sir.
Reduce dose, yes or no?
No.
No, sir.
No.
Infliximab, yes or no?
No, sir.
Why no? Someone who is not responding to steroids, is infliximab an option still?
So maybe.
Add on.
Infliximab is contraindicated in immune-related hepatitis. Okay,
Okay, sir.
that is the
We should
reason they have
discuss.
asked. I
Okay,
don't know
sir.
whether human asked or an AI asked. They want to dig into all these details. This is not even
So
a
we can
question
give
for a med.
mycophenolate mofetil instead of
See,
infliximab.
you start steroids, and most of the time, it is steroids the answer for a hepatitis. Okay,
Okay.
because if they are not responsive to steroids, it is not going to respond to other agents like steroid sparing agents. And it is the duty of a hepatologist to see whether he or she needs a transplant and other stuff. Got it? No point in targeting your immune system alone when they are not responsive to steroids. That is a funda for doing this.
Okay.
If steroid refractory, consider liver biopsy to rule out NASH, tumor, cholestatic variants, other drug-related hepatic inflammation infection, and consider adding azathioprine if infectious causes is ruled out. So these are very daisy terms to be taken into account only after so many considerations. Clear?
Yes, sir.
Yes, sir.
So the answer was
C.
discontinue and put on steroids. Okay. Radiation pneumonitis management.
Steroid.
Steroids.
For which grade onward steroids? All grade steroids only. Chaniya. Grade 1, if it is not worsening, then you don't do anything. Grade 2 onwards, you start them on steroids. Okay.
Yes, sir.
Right. NBC, ovary, what is the chromosome?
13q.
Which one is involved?
BRCA2,
One or
BRCA2
two?
maybe, sir. Usually BRCA1 involves, sir. But
But there was no option of a 17q.
Okay. That is no option of 17q. You can you can very well say it is BRCA2. Why do we confuse? Right?
Yes.
Right. And who discovered BRCA? And what is the full form of BRCA? Any idea? These will not be asked.
The multiple California.
Okay, very good. That is what I wanted. So Berkeley, California is because
Was named like Mary Sinclair named after a friend who discovered it.
Yeah. So there are so many reasons for the name, but the point of keeping the name as BRCA was not behind breast cancer. Okay, that is the answer here. Mary Carey King discovered and wanted to keep the name in terms of BROCA, Broca, Paul Broca, who was a pathologist long back, who could tell that there is something involved in a family who is having a breast cancer. So they did not know BRCA then. He just found out that a pedigree might actually have a familial inheritance of breast cancer. So that was supposed to be BRCA. And it was found at Berkeley, California University. Berkeley University, California. What is this? I don't know. Score of 18. What is it? Mild, moderate, severe.
Mild only.
You'll have to sit and calculate. All
It is
these are
given
beyond
as moderate, sir. It is
this.
replica of one of the question bank of one of the platforms, sir.
Horrible. Horrible to the core. Anything is going on behind this question paper issues? Or is it like the same old NEET? Just people start making noise the initial time and then it is all down.
That's what's the
Nothing
same,
is
sir.
going on, sir. Everyone is quiet.
Mhm.
Nobody is.
The BC NEET told people started having so many centers had open-ended books discussions. So many people were taking net. A list of people got first mark, full mark, who were actually faking. But then it never turned out to be, investigated a lot. I think this will also go off like that.
Yes, sir.
And also people will go off from dark tutorials. That is what is going to happen. These people have to find out what is the best possible way. 50 years of male, 40 smoking years. What is this?
Small cell.
Small, sir.
Small.
Small cell.
Small cell. Right. I think were there really so many questions, or because of recall we twisted the questions this way?
No, sir. There were so many questions. They were like SVCO, febrile neutropenia, and tumor lysis. So many questions.
Muscle invasive bladder cancer. What is in your therapy of choice?
CDDP plus GEM.
Right. So now GEM carbo also given, GEM CDDP also given. In the current era, what is your choice?
Durva Gemsis.
Durva GEM carbo, okay, huh? Patient is not cisplatin eligible. Is this okay? The criteria is supposed to be like patient should have had cisplatin. Okay. Just
Okay.
an add-on for you to remember whenever you read the trial, get into the depths of the inclusion criteria. Right? That is what is going to make you think who should be offered and who should not. I have a patient with GEM carbo Durva. That is a totally different story. Practice is different, but when you're reading up the trial, you need not remember all the inclusion criteria, but when you're applying it to a patient, just find out if you're deviating from a trial, because if then you cannot expect the same results of a trial. Okay. You should be able to accept what is happening on a real world. What is the scoring? Right.
Multinational association of.
What are the other chromosomes?
Check 218. Ovary.
Both are Wilms tumors.
WT1 and WT2.
Magar syndromes. Okay. What is this?
MASCC.
Multinational association.
Apache for
Apache sofa.
Pancreatitis.
pancreatitis. Very good. Glasgow for
Glasgow coma scale.
okay. Good. Cancer cachexia, increased fat stores. Okay. AI, please leave me. AI, leave me. That's all. Right. Now, other things which you wanted to discuss. Each one of you contribute and let's start discussing what is required. Yep.
So that cisplatin cardiotoxicity question, what is the answer for that?
So what will be the answer of question 130? GEM cis or GEM CDTP?
GEM cis only.
GEM.
It is alterable, but when given a chance of these two, it is always GEM cis. That is why I quoted your trial, because trials want beyond this one more point of discussion. What are the criteria to say patient is cisplatin eligible or not?
So nephrotoxicity grade, ototoxicity, and
Sorry, where which age you are not supposed to give cisplatin at all?
Usually in head and necks above 70.
so
71
Galsky
fit,
criteria.
65 frail male. Whom are you going to do? Yes or no?
The frail patient we won't give.
So is there an age criteria for
So age is
cisplatin?
not included, sir. Age is not included in Galsky criteria.
No. That is what is the question. So age is never a criteria to decide on cisplatin eligibility. Okay.
Yes, sir. So it's
Got it?
performance status,
Take home
neurofunction.
points. One, age is not a criteria. If given an option of cisplatin and carbo and patient is cisplatin eligible, you still choose cisplatin over carbo in bladder cancer. Though we tell if patients are not eligible for cisplatin, carboplatin is not inferior because there was never a comparison which was going on. Okay. In ovary, they have proven that paclitacarbo and paclicis are equal.
Yes, sir.
No such things could be proven, even though if they have some rare case reports and smaller trials, strong evidence of equating these two did not happen, will not happen also. Okay. Right. Now, what are other points for discussion?
So
Cisplatin
cisplatin
cardiotoxicity.
cardiotoxicity, what is the answer for that?
So what were the options?
The options were ischemic heart disease or MI, systemic hypertension, pericarditis, and QT prolongation. It's question number 13 from the
1-3,
PDF.
huh?
Yes, sir.
So it's not in this, it is probably the first one. Fair enough, doesn't matter. So the options were
Ischemic heart disease or MI, systemic hypertension, pericarditis, QT prolongation.
so we'll go one by one. Rhythm disturbances, yes or no?
Yes, sir, but they were not in the options. Atrial fibrillation is there, but it's not in the options.
Right. So what is the most common from whatever we have read now?
MI, but it is still rare among the ADR. The others are not even given: systemic hypertension, pericarditis, and QT prolongation. They said IHD or MI, it's less than 5%.
Yeah, because platinums can cause vasospasm.
Okay, sir.
Most of us is not. That is our reason that they have given that is possible. Any other contradictory question answers?
The oxaliplatin cardiotoxicity question.
No, for this question, are we in a consensus that it is MI? Or do you have any friends from the other institute who has possibly this question also in their question bank?
No, sir, it was not there in any question bank, sir.
Thankfully,
It's
they did
just
not
half
take the
line in Devita and one line in the 2 Devita.
as to what?
That MI can occur in this cisplatin.
Can you tell me where was the which chapter?
In 2 Devita and cisplatin, it is 8th or 9th number, and cisplatin, I have sent you the same screenshot, sir. It's in the cardiotoxicity chapter in 11th edition. No, in 12th
Can you
edition.
just share that? Can you just share that from your end?
So should I put it on group?
Yeah, you can put it on the group. That is well and good. We can
Okay, sir.
just put on the group so that we are able to understand where do we stand in this question.
Yes, sir.
Plus, other chemotherapeutic agent as usually ischemic events, particularly when combined with bleomycin and milk alkaloids. That is the problem. They don't give exclusive things here.
Yes, sir.
Though MI is rare, but so even now, after all this, no consensus. Because it did not give, there was an atherosclerotic plaque, this, that. So most common, still, I'm also doubtful. With all the search which I have done, I didn't get a single answer for that. There are case reports of arrhythmias, case reports of even pericarditis, case reports of MI. And each, the best thing about anything being rare, and when you want to read, go to the discussion part of all these trials and stuff, and start reading the discussion part. Start to read the trial from the discussion part, not from the. So when you have completed the abstract, go directly to the discussion. Easy for you to understand, because they will give the comparisons of with the other trials. Why did they think? What are the limitations? And so many stuff will be inside. After which, going to your results and reading is good. Okay, abstract will tell you a gist of the whole trial. So that is easy for you to just have a small overlook. After which, go to the discussion. And whenever I went to the discussion of all these cisplatin related cardiotoxicity, theoretical papers, every discussion gives their own experience. They don't have a single answer for that. So most common when they ask, it's very tough. Any other question?
So
And one more
question
thing,
number
paclitaxel
25.
hypersensitivity is also a cardiac toxicity from the data. I think Krishna Reddy sent me.
What, sir?
Yes. Hypersensitivity is one of the cardiotoxicities for paclitaxel. That day we doubted whether it is hypertension or hypersensitivity.
The non-ischemic, it is not associated, sir. So
Yeah.
non-ischemic cardiomyopathy is not associated.
Yeah. Acceptable. Clear. So hypersensitivity is a cardiotoxicity. Non-ischemic cardiomyopathy is not into the commonest pools, or not at all into this paclitaxel. Any other question?
Yes, sir.
10 to 10 questions. Ambiguous. Refractory CNV. What is the story?
Yes, so that
Was
is
it
question number
take through?
4.
Yeah.
I think 5.
Was it
So they ask,
refractory
what
break?
will you do, sir, for such refractory cases?
Even that, benzodiazepines are right. Olanzapine is right. I also thought benzodiazepines only for a anticipatory vomiting. That is how it has been approved, and that is how it is being practiced. But when it comes to refractory, everything is getting into the picture. So we don't know which is not there.
So they have given aprepitant, haloperidol, benzodiazepine, and increasing dose of 5-HT3 among the options.
Increasing dose of IHT3 is not the story.
Yes, sir.
Next.
Further D2 blockade with drugs like haloperidol.
So that is also into the options. Your benzodiazepine is in the option. Aprepitant for next cycle is in the option. Whether they are asking for this cycle or next cycle.
There
So
were
they just
two
ask,
questions,
what will
sir.
you do for refractory cases?
So obviously for this cycle only they are asking. That is how we have to understand. Am I right?
Yes, sir.
So it is either haloperidol or benzodiazepines. So at least 2 answers now. What to choose among the two? No idea.
Okay,
You don't have a comparison between both. You have a comparison between olanzapine and metoclopramide.
Okay, sir.
Anal cancer
Sir, can
histology.
you enlighten?
Yes, sir.
Can you like what?
Sir,
Someone wanted
can
to
you
ask.
explain more about stage 1B cervical carcinoma management, as both radical hysterectomy and CCRT followed by brachytherapy are not acceptable? That is the confusion. Because one option was CCRT followed by brachytherapy was there also.
Yes,
So
yes.
isn't that acceptable in stage 1B?
That is acceptable, right? Given an option, that is an acceptable answer. But if you are, if they have given 2B onwards, it is an easily acceptable answer because there is no other option, right?
Yes.
They have 1A. Again, surgery is the easiest answer because you don't have to bang on what to do, whether radiation or not, right? So
Yes.
these two are discrete answers.
Yes.
1B1, 1B2, and 1B3 to A. In this group, you have 2-3 options. One is surgery, followed by surgery, which is radical, which includes your hysterectomy with lymphadenectomy, with or without para-aortic lymph node involved in removal, followed by radiation based on the criteria, followed by chemoradiation again based on the criteria. Clear?
Sir, in this question,
Yes.
since like post-op criterias were not given, like the biopsy was not given, so can't we choose like it would be surgery would be an incomplete answer. So can't CCRT followed by brachy be an ideal answer?
Because in option radical hysterectomy was only given. It was not given radical hysterectomy with lymphadenectomy. So we should choose surgery or this CCRT followed by brachy. That is the confusion, because they did never write lymphadenectomy in any of the options.
Lymphadenectomy as a word was not given. That is your
yes, sir,
argument,
yes,
right?
sir. Yes, sir.
So that is also actually it is an acceptable story.
Sir,
If you
but for
actually
1B2, we will give RT alone followed by brachy. We won't give CTRT. CTRT is for 1B from 1B3 onwards. For 1B2, it's RT alone followed by brachy.
But that was never an option, right?
Yes, sir.
Again, back to confusion. But if they have not, see, radical hysterectomy is just removing the structures of the uterus and the surrounding structures. Okay.
So in radical
Lymphadenectomy,
hysterectomy, we do pelvic lymph node dissection, no?
yeah, true.
It is included
again-
in the definition of radical hysterectomy.
Again, I'm speechless now. Oh, why didn't they give lymphadenectomy as a word there? What do they want to derive out of this? No idea.
So when we
Plus
talk of
A,
simple hysterectomy or radical hysterectomy, like when we say radical hysterectomy, it means that lymph node dissection is included in that.
just like MRM.
Yes, sir.
But if it is to be CCRT, they didn't mention anything like it is medically inoperable or this kind of thing to favor towards the CCRT, sir.
The
So
CCRT
an incomplete question with all options available, which are all right. Back to square one, confused. So whatever is their option which they think is right, and whoever has answered that right in whatever logic it is, will be the winner here.
And sir, one question regarding radical hysterectomy, in oncology, we might consider lymph node to be taken for granted, but in general, radical hysterectomy doesn't, I think, include lymph node
The
dissection.
definition does not carry lymphadenectomy. That is what you're trying to
Yes,
tell.
sir. Because yes, sir, in gynecology, they never remove lymph node for other procedures of other indications
Of
of
radical
radical
hysterectomy.
hysterectomy, benign indications of radical hysterectomy.
Yes, all what we spoke now are logical correct answers. But what is the right answer for that question? Don't know.
Yes. And sir, one thing about neutrophilic dysfunction in chemotherapy, can you explain that? Because like the mechanism of neutrophilic dysfunction, mechanism of febrile neutropenia is apoptosis, But they specifically mentioned in two questions neutrophilic dysfunction. So is there any specific answer for that, or we should go for apoptosis anyways?
So it was like
Neutrophilic.
functional neutrophilic dysfunction. It was like not due to the number of neutrophils. Like they
Yes, sir.
specifically emphasized the functional impairment of neutrophils.
Yes, sir. That is why we got confused.
No,
Because it is
they have asked this as a question, and what was the answer?
so
So the
one was
options are
apoptosis.
CXCR downregulation and less chemotaxis, NADPH oxidase dysfunction and phagocytosis, chemo-induced neutrophil apoptosis, and maturation block of neutrophils. This NADPH is seen in chronic granulomatous disease, but I don't know
Yes.
about CXCR downregulation and maturation block.
CHCR's down regulation is not the answer for sure. Maturation block is again a doubtful story there. All these mechanisms are possible. That is a problem here. And the most common mechanism is apoptosis for a febrile neutropenia. They've asked for a neutrophilic dysfunction in without a number as a without number of neutrophils as a criteria, and pointless again. So at least I think by now we have discussed some 5 questions without answers, right? Both cisplat cardiotoxicity, paclitaxel cardiotoxicity, your neutrophil story, and then what, CINV and your cervix. No idea what is the answer. Anything else?
The anal canal histologies.
I think one of you had all the screenshots shared to me. Can you put up in the group?
Yes, sir, I have already shared.
You put up in the group as well. You just
Yes,
now
sir.
put.
Just now.
So what is the answer?
Sir, among non-squamous, they have included adenocarcinoma, small cell carcinoma, neuroendocrine tumors, undifferentiated carcinomas, melanomas, rarely lymphomas, and sarcomas. And in perianal skin, they have included uh, small cell carcinoma, squamous cell carcinoma, verrucous carcinoma, giant condyloma, Buschke-Lowenstein tumors, condyloma acuminata, Bowen disease, Paget's disease.
So
Sir,
all the
can
options are
Bowen's
possible.
disease, sir, can Bowen's disease occur in anal canal per se, not like perianal region?
So then even Paget's is also of like perianal only.
All the options were possible. If
So basal cell carcinoma is not there. Melanoma is there, but BCC is not there.
when you search BCC in separate,
There will
you'll
be
have
some
an
rare reports, case reports.
So what has been the classic teaching is case carcinoma lower rectum versus carcinoma. It will be called as carcinoma anal rectum only when there is a adenocarcinoma component in it. It will be carcinoma anal canal if there is no adenocarcinoma component in it. There
So
is
what they
a
have given is a suspected anal adenocarcinoma may actually reflect an extension from a distal rectal adenocarcinoma in some situations. Mucinous adenocarcinoma is generally thought to arise in the anal glands and ducts and is uncommon. It should be noted that histology is generally more important than location within the anal canal and usually dictates overall patient management.
too much into the books are also toxic. Even BCC is in NS perianal, it is given 1%. I don't know how did they arrive with this 1% also. How many percentages they have seen?
So why are they asking such rare things like cardiotoxicity and
This is
BCC?
not rare. Rare questions will have answers. Okay, this is not rare question with a rare answer. There is no answer here. Someone want to discuss hypercalcemia. Can you be a little loud? What is the doubt of hypercalcemia question?
I don't know. So I want to ask about DOACs versus low molecular weight heparin.
Which one?
DOACs, when to use DOACs and when to use low molecular weight heparin. Because it is said that DOACs are contraindicated if there is high risk of bleeding, like in GI cancers.
Okay.
So, like that question was for RCC. So, will RCC also have high risk of bleeding? Like, what about urothelial cancers and
No,
RCC?
no, nothing like that.
Okay.
So,
And so, for, when will you use low molecular weight heparins for DVT? Like, it is used as a bridging therapy, no? Like, after we use for 5 days or 1 week, then we again shift to DOACs, no?
yes.
But that option was not like that. It was like low molecular weight heparins for 6 months
But
directly.
there is no, not everyone will have a newer molecule which is there. In institutions like mine, we give heparin, low molecular weight heparin for 6 months. Before these newer anticoagulants came into picture, it was low molecular weight heparin for 6 months.
Okay, sir.
Anything else? So 6 bizarre questions.
Sir,
So,
regarding the question on SVCO in lung, the most likely diagnosis, so shouldn't it be non-small cell lung cancer? Because even in smokers, squamous is more common than small cell lung cancer.
To interpret SVCO, commonest is small cell. That
Sir,
is all.
there were two questions on that SVCO, sir. One was most frequent histology being seen, and another was like most frequent,
likely
like most common.
Okay.
Most
Then
common one.
most frequent histology causing an SVCO is small cell.
Another was
Right.
most commonest type, sir.
Most common should be NSCLC then,
Okay, sir.
because squamous cells are occurring so much more. Even if you have some peripheral, so much more into the mediastinum as well.
Sir, even if
From
it is seen
SVCO point of
associated with
view,
smoking.
from SVCO point of view, which is the most common? It is small cell. From a lung cancer point of view, what is more common causing SVCO? It is squamous.
Sir, even if they are saying smoking associated, then also will it be non-small cell?
No, why not non-small cell? Non-small cell can occur without smoking. Doesn't mean it should always occur without smoking.
Yes, sir. Okay.
How much percentage of adenocarcinomas are non-smokers?
majority adenocarcinoma are non-smokers only.
Majority is equal to. When we discuss the next time, I want the number exactly. I don't want you to feel the number.
So that paclitaxel hypersensitivity question, what is the answer for that?
Paclitaxel only. Sorry.
So what will we do?
Cardiac.
No,
You're asking
paclitaxel
cardiac.
hypersensitivity.
I don't remember the question.
Hypersensitivity reaction after paclitaxel, what will we do? Like
No.
next?
Oh, the epinephrine or whatever.
Yes.
My practice is easier than your MCQs. No idea again. 10 by now, 10 questions, all without any answer. Even I did not have. Sorry?
Regarding that, sir, SVCO, please, if you can, like, I have the doubt because in video section, like you told us that if patient present with SVCO as the first presentation, then most likely it will be due to small cell because symptomatic is
So from
mostly
the
small cell.
SVCO, when you take SVCO is the as your first liner, and then you see which is the most common. Small cell is the most we tend to always associate this way. The paraneoplastic syndromes or the other emergencies of oncology.
Yes, sir.
Superior vena cava syndrome as an emergency in small cell. Hypercalcemia as an emergency, squamous cell. This has been a very discrete discussion always.
Yes, sir.
The confusion comes when you wanted to think NSCLC is so big in number, just like your breast cancer causing your leptomeningeal disease.
Leptomeningeal mets.
Because it is so high in numbers, others which can easily go to leptomeninges become less common than breast because the numbers are very big. If you are discussing from that end, so if your discussion starts from the lung end, then it is more common with the squamous cell. So from which perspective are we going to see? Again, twist of question, most common histology, most common cancer presenting. Tough, man, extremely tough to even substantiate myself. How does the AI give you answers in this?
The answers differ from AI to AI.
Oh my God.
We should find out which is more authentic.
Even AI is not authentic. I'm now happy. I'm all not inferior to AI now. All are confused.
So for that malignant pleural effusion question,
Even if the
because
AI
of
is paid version, will it differ?
yes, sir.
I don't know. Paid version versus non-paid version, there is a difference.
So it's ultimately how you frame the question, what prompt you give to it.
Understood. Yes.
So that malignant pleural effusion question, because of Warburg effect, there will be lactate formation, no, due to aerobic glycolysis. So wouldn't that lower the pH in pleural effusion?
When that
malignant pleural effusion, the question was the patient has the pleural fluid has low pH.
Yes. Warburg effect. Yeah, that is one of the reasons for low pH. But usually when they want to ask, but that is very clear when you discussed also, when a malignancy with huge effusions, massive effusion, we don't expect a massive exudate with the patient presenting to you with only breathlessness and it is all bacterial. And when there is already a background given as malignancy, patient with malignancy, and malignancy is possible for exudate, unless until you kind of confuse yourself with the malignancy as a straw colored and transudate. If that is a confusion, then there is a problem of marking it as tuberculosis or bacterial. But malignancy, yes, exudative effusion. And in a patient, and the option given as malignant lung cancer, in the answer, it is malignancy, the reason for exudative effusion. Clear?
Yes, sir. And so in the definition of Cairo-Bishop criteria for lab TLS, it is defined as 2 or more of the metabolic abnormalities 3 days before to up to 7 days after starting cancer treatment.
Yes. The 3 days before is to for the spontaneous one.
Okay, sir. And so we have that option of 1 to 5 days and 5 to 7 days. So what will be the answer?
1 to 5. You can never leave out the initial 5 days and mark it later.
Okay, sir.
But to be very frank, really very tough exam. I don't know how a NEET can go this tough.
It's not tough, it's more unpredictable.
Yeah, that is a problem. Tougher in the sense, INI tougher, and the previous NEETs were, the question was tough, not like this bizarre questions.
Yes, sir.
Sir, any specific advice regarding INI preparation, if any?
INI preparation, we are updating the videos. I think so. The problem is we don't know where to place our discussion all, because initially when these people asked and when we wanted to train people were from MD background. and
Yes.
MD background people need to understand oncology. So we kind of did only very basic stuff on for oncology, like
Yes.
what is hormone positivity, what is ER, what is PR, what is HER2. This basic was the discussion in a video also. But now all your discussions are beyond a basic. We thought we should do according to the guidelines per se.
Yes.
Even now I am confused as to how the video, if a video is supposed to be done on a breast cancer, now I have done all the split of TNBC separately, hormone positive separately, and HER2 separately
Yes.
as adjuvant and metastatic. But the discussions are more with the guideline based material like your NCCN and all your newer updates. Whether that
Yes,
will be really asked also as a doubt story, because from what we understand from INI and NEET, they want to dig into the basic stuff a lot, and um, and your thought process on a systemic oncology than the newer drugs, updates, trials. I don't think those were ever a question.
Sir, will that be updated version of video will be available before this session or in the next year only?
No, we are trying to work on that. The problem is again back-to-back stories. Now, I thought this week I should have finished the video, but this week went off with all your INI. So it is well and good if you tell us what is easy for you to go through and understand. That way we can make. Which way do you want? I started discussing from an NCCN guidelines of adjuvant and neoadjuvant, then ramification from there, trying to explain why, what, and what not.
But so they hardly ask anything about solid cancers
Yes,
in
sir.
this exam.
The systemic and staging regarding treatment were very less. Mostly was general onco and specific chemotherapy related side effect. Like earlier, they were only limited to what is the side effect, but now they were asking the next step how to manage the side effect that we are not familiar much with.
And to remember every next step of every side effect of every drug is
Yes, sir.
practically not
Yes, sir.
possible. You just can have an overview of what yes or what no, and then think from that and answer.
Sir, one more last one thing, just as like 1 month is remaining for INI, and like we have like me.
When is your possible INI date?
Around 15
Third
to
week
30
of-
May probably.
Huh?
15th to 30 May is probably all are saying.
Right.
Yes. So like
When is your NEET results coming out?
30th April.
30th.
Hopefully it comes. Right. So from what you have answered now and from what you have understood in the INI questions, the so-called INI questions, what do you think is the right way to make a video on? If you want to, what will you find it good when you want to see a video on breast cancer? What do you want from that?
basics are already
I want
covered.
to
Yes, sir.
I see. You might have little well-read from your PG days. I'll have to address both. A person who is new to this possible oncology, and also a person who should not get bored up with the basics.
So
Like,
for mostly first line management.
So I think our discussions have to be placed there, not too much of recent stories.
So any idea about cutoffs?
Sorry?
So cutoff for this NEET?
No idea. No one can have an idea of what this is. This is just like you people, a first need. For us also, it's a first Medonc need. All questions from Medonc, and with all these hi-fi questions.
So I have one doubt. Like last time you told us that olanzapine can be used for cancer cachexia. So it will help with the muscle loss seen in cancer cachexia. Is it like just a repurposing, or like is it a standard indication of olanzapine?
These are newer trials coming into the guidelines. It is not standardized still. Okay.
So it will help with muscle loss also, like how anabolic
It is
steroids.
helping mainly with appetite. Second, just go back, read JCO, Jipmer, olanzapine, and cancer cachexia. These 4 keywords, you will get some answers. These are from
Jipmer and cancer cachexia. Olanzapine.
olanzapine, cancer cachexia, JCO guidelines,
Okay,
Journal of Clinical, right? But the problem is all these are cutie guidelines, small guidelines. So none of them are a standardized question. And to twist a question in what is the most common histology, what is the most common cancer, it actually doesn't make any sense. Like what is the most common druggable target, KRAS or EGFR, because RAS has got a target now, but it is still not a first line, it is a second line. All these are unnecessary discussions actually. And if someone is framing a question on this, has actually no meaning because it's a evolving story, obviously.
It's irrelevant clinically, like the questions which
Extremely
we have
irrelevant. Does sotorasib, any idea where is sotorasib approved?
second line and non small
KRAS.
significance. KRAS
G12.
G12C mutation.
E2L,
C.
where? Lung,
Non-small cell, yeah.
lung.
Second line.
Anywhere else?
Yeah.
Anywhere
Pancreas
else?
also.
Cholangio.
No, anywhere else along with an EGFR inhibitor? Panitumumab with sotorasib is approved in colon, okay?
Colorectal cancer. Okay.
Colorectal cancer with RAS mutation. Go back and read the trial if you can. It is all a horrible conclusion based on all statistical jugglery and English being used in different manner of describing a negative trial. P value is 0.02. Sensitive, significant or not?
0.0.
0.02. Significance, yes or no?
Less than 0.05, so we can reject the null.
Significant.
So it is significant. But hazards ratio is 0.8 with 0.6, 0.8 with 0.6 to 1.13. Yes or no? Is it significant or not?
No, sir.
No. So now with these two extremes, one is showing significance, one is not showing. What do you tell? Positive trial or negative trial?
We can't tell.
You can tell it is a negative trial. You cannot claim a p-value significance alone because it is based on your sample size and your calculation. It doesn't take into account the risk reduction, right? So many outcome parameters are there. You need to prove statistical significance based on what you wanted as an outcome parameter in the primary endpoint. You cannot say primary endpoint is negative, but the p-value is positive. Okay.
Yes, sir. So there's a question on median on OS. I have forwarded in the group. Will you please explain it?
Can you ask the question again? So many groups, so many questions. Very tough to follow. That is the reason I ask you to clear your doubts now.
Okay, sir.
Okay.
So
What? Meanwhile, pembrolizumab with the lenvatinib. Where is this combination used?
Endometrial.
Anywhere else?
RCC.
RCC. What is the comparator of RCC in pembro lenvatinib?
Axitinib pembro.
No. Pembro lenvatinib was compared with what? Sunitinib. Okay. All your immunotherapy trials are compared with sunitinib. So if you are the question is TKI with IO is better than TKI alone. That is the question, right? So they should have put sunitinib with pembro better than sunitinib. They cannot put another TKI which can have a totally different story. Yes.
Yes, sir.
So this trial should have been designed in a way pembro plus sunitinib better than sunitinib. That is how they are supposed to design a trial. But then they design in such a way that pembro plus lenvatinib is better than sunitinib. Why is this?
No, sir, then sunitinib was the standard of care, like when they provided.
Correct. But in the in the experimental arm, you are supposed to combine IO with the standard arm, right? You cannot compare lenvatinib versus sunitinib. Actually, if this pembro lenvatinib is working well, we don't know whether it is pembro making the difference or lenvatinib making the difference versus sunitinib. If you are actually putting up pembro sunitinib versus sunitinib, you know pembro is actually making the difference, correct?
Yes, sir.
But then why is this bizarre story? This is mainly because of pharma industry. By the time they wanted to design this trial, sunitinib was losing its patency. So they cannot. Just to make sure, so they wanted to make money. They put lenvatinib there. Got it? So this is I'm not making up a story. This is the reason for such a trial. So many such trials are there. Got it?
So the generic version of the drug would be made and they will lose the money. So they made lenvatinib
So
as the
want
trial.
another combination which will still not have lost a patency.
Yes, sir.
So many such things are there.
We have to read between the lines also. We cannot believe everything the pharma people feed us.
Yeah. So pharmacy will aid like AI, but doesn't decide what you are going to think.
Yes.
Okay.
So
All
this
philosophy.
question,
Anything else to discuss? Something else you want to discuss? What is that?
yes, sir, this question about median OS. In the setting of malignancy, Kaplan-Meier graph was compared between palliative arm and chemotherapy. Median survival amongst two was found to be 4.5 months and 9.5 months respectively. So what is true? Like how will you interpret the median OS
4.5
benefit?
months median OS for what?
Palliative
Palliative care.
care.
Chemotherapy 9.5 months.
Yes, sir.
Okay.
So how will we interpret it? Like, can we say like it is doubled in the chemotherapy arm, the probability of survival, or will we say that the median OS has increased by 5 months due to chemotherapy? Like, how will we interpret it?
You can tell whatever way you want. Doesn't matter. 1.5 months with palliative therapy, 3 months with chemotherapy. Still, they say it is doubled. There is no meaning of this double only.
So what option should we choose?
So this was an MCQ?
Yes, sir.
And doubled versus 5 months increase was there?
But so they are saying the probability of survival. It is not the probability of survival. The probability of survival in median OS will still be 50%. Like even for a palliative arm, it will be 50% at 4.5 months, and it will be 50% for chemotherapy at 9.5 months. It is always be 50% the probability of survival. So it's not like the probability of survival is doubled. It is the survival time which might have increased or doubled.
The y-axis can have two options. It can have overall survival or it can have probability of overall survival. Probability of overall survival in the y-axis is given for those trials who have not a mature OS data. Got it?
Okay. It's like when we calculate a PFS benefit.
No. If your primary endpoint was OS and suddenly an interim result is out,
okay,
which says X month is better than Y months, and still the data is mature only 30-40%. What is maturity of data means?
If we cannot calculate the median OS, like the trial is not
No,
complete.
not that. Even with the immature data, you can still calculate. see, when you are designing a trial, obviously you will put so much events should happen for you to decide on the overall survival. Yes, like
Okay.
100 deaths should have happened by this timeline for me to decide overall survival, which is better than which. If that event rate is happening at the desired rate and that is completely done, then it is fully mature. If only 30 deaths are done and 100 deaths are the designed one, then your data is still not mature.
So we fix the criteria for maturity before the trial is complete. Like before, when we design the trial only, then we fix when
We
we'll
design
call
the
it.
trial only, we know what is, when do you call it as a mature data? That is why many of the trials will have PFS answer and then OS data is still maturing. That is a line which is given.
Yes,
And
sir.
when the OS becomes positive, there will be a huge noise around that. Any more discussions?
Yes, sir.
Close the session today.
Yes, sir.
Thank you.
Thank you, sir.